Good morning, everyone. We're having a few more attendees join, and we'll get started here in just a moment. Welcome to the Project Friend webinar on November 10th. Okay, well, good morning, everyone. My name is Dr. Mary Mercer from UCSF and San Francisco General Hospital. I'm one of the co-directors for the program called Project Friend, which stands for First Responder Increased Education and Naloxone Distribution, and also serve as the base hospital medical director out of San Francisco General. We're really thrilled to be hosting this webinar today around substance use disorder and innovations in the EMS and pre-hospital space around substance use disorder treatment, management, and harm reduction. And so we have an all-star lineup from across the country and local all-stars here today to share best practices with you in a range of substance use management issues. So I will introduce our group of panelists in turn today, but to lead us off will be Dr. Melody Glenn from the University of Arizona, discussing management of opioid use disorder in the rural borderlands. We're also thrilled, particularly as Melody has a special connection here with us in San Francisco, having been a former EMS and disaster medicine fellow and contributing during her time in San Francisco to the community paramedicine training program here with the fire department. So coming full circle with our other panelists today as well. Following Dr. Glenn will be Dr. Charles Murphy from UCSF, who will be discussing alcohol use disorder management with naltrexone in emergency departments. Then after that, we have Captain Michael Mason of the San Francisco Fire Department Community Paramedicine Division discussing rapid treatment of opioid use disorder through a community paramedicine and public health intervention. And then a special guest of Dr. Hillary Kunins, the new director of behavioral health in San Francisco, discussing the behavioral health systematic response and the overdose crisis response of SFDPH in San Francisco. And finally, an overview from our program director, Dr. Kathy Lesaint of Project Friend, to provide an overview and update of developments for the Project Friend program out of San Francisco General. So I will ask our panelists to, those who are not going to be speaking, we'll change our videos off, and I will turn the floor over to Dr. Glenn to share her wisdom and learnings with us from Arizona. Thanks.
Thank you. Thank you, Dr. Mercer, for that great introduction. So jumping right in, we're talking about pre-hospital management of opioid use disorder in the Borderlands in Southern Arizona. So I have no financial disclosures, and Dr. Mercer already did a great introduction of my background. As she mentioned, I did my EMS fellowship at UCSF. I am currently working at University of Arizona, where I'm an emergency medicine physician, an EMS physician, and also addiction doc. So I primarily work in the emergency department, but I also am a base hospital medical director, which here is a little bit different than in California. Here, the base hospital medical director is basically the medical director for several small fire departments. We are primarily fire-based here. And I also work at a methadone clinic. So I try to merge all these fields together. And when responding to overdoses is the perfect way to do that. So today's talk, we're going to have four main topics that we're going to. The first is just introducing you all to Southern Arizona, telling you a little bit about this special place, introducing our protocol that our crews follow, show the data that we've collected in the last year that we've been running. And then if we have extra time, just a little bit of fun factoids about the history of addiction and EMS. They've been linked since the beginning. So let's talk about Southern Arizona. This is Nogales, ambos Nogales, so both sides. There's the US and in Mexico and Sonora. The US side is much smaller, it only has 20,000 citizens, where in the Mexico side in Sonora, it's 220,000 people living there. So it really is a city divided by a wall. You're used to a lot more free movement back and forth. Lots of people cross the line. They call the fence the line here. They cross it very frequently. And Nogales Fire Department is the biggest fire department that I work with in Southern Arizona. I also work with the other fire departments in Santa Cruz County. So the map of Arizona on the left is all of our counties. The one that's a darker blue on the US-Mexico border is Santa Cruz County. So you can see it's a very small geographic area. There's about 10 fire departments there that we work with. It's really beautiful country. A picture on the bottom right is what it looks like. These sort of rolling hills. It's a little bit higher elevation than the Sonoran Desert where I live in Tucson. So there's no big sorrel cacti or anything like that in Santa Cruz County, more mesquite trees and grasses, lots of ranches out there. And Nogales is the biggest city in Santa Cruz County. Santa Cruz County is one of the poor counties in Arizona. So 26%, a quarter of the population lives under the poverty level. The unemployment rate is slightly higher than the rest of the state. 15% of people who live in the county are uninsured. And that might be related to part-time status. We have some snowbirds in some of the rural towns outside of Nogales, and in Nogales proper, people are probably going back and forth in Mexico, many Mexican citizens who are living there. In the county, 84% are Latinx, and in Nogales proper, 95%. So it's very much a different environment than the rest of the state. And it's really fun for me. When we go to the fire department, the crews are often speaking in Spanish. People have family on both sides. The Borderlands really are a unique environment. It's also a pretty young county. So about a third of the residents are under 19 years of age, and 37% between ages 15 and 44. And that's the age group that you all know is most likely to experience overdose. There's also concern being close to Mexico that lots of illicit fentanyl is coming up through the border. Fentanyl is the main opioid of choice on the US side. I was looking at a report done by an epidemiologist and a physician based in Mexico, and her report showed that the opioids are more of a problem on the United States side, and alcohol is more of a problem on the Mexican side. So opioids are a uniquely American thing, even though we might be getting some fentanyl from south of the border. There's also a shortage in healthcare workers in Santa Cruz County, especially behavioral health professionals. For every 2,200 people, there's only one behavioral health specialist in Santa Cruz County, which is a lot for the majority of the United States. For every 370 people, there's one behavioral health specialist. So we don't have a lot of options when it comes to substance use disorder, which makes it even more important for EMS to be involved. As I mentioned, fentanyl is the primary opioid of choice in Santa Cruz County and Southern Arizona. About 70% of our overdoses involve illicit fentanyl. According to news reports, I don't know how true these are, but if you look at mass media, they talk about the fentanyl smuggling across the US-Mexico border has been increasing dramatically. For example, in El Paso, which is a similar border town, much larger than ours, the rate of fentanyl smuggling has increased over 4,000% in the last 3 years. And from a medical perspective, this matters because fentanyl is deadlier, as we all know. And from working in the addiction side, it's also sometimes harder to start people on that when they're coming from fentanyl onto medications for addiction treatment. I have a harder time starting people on buprenorphine. They're more likely to go into precipitated withdrawal. And I've found that buprenorphine is less likely to satisfy their cravings. This is all anecdotal. There haven't been any big studies on this yet. But if you start talking to addiction docs, this is seems to be commonplace. Hopefully there'll be better, robust research on this in the future. I even reviewed, so I review all the overdose calls in Santa Cruz County, and I have reviewed some that, so I-19 is the main freeway going from Nogales north to Tucson, and there's Border Patrol checkpoints along it, not just at the port of entry, but also 100 kilometers in. And we have gotten calls for people who have been packing and stuffing fentanyl into tubes and crevices. I won't go into too much detail there, you can imagine. So here is our protocol that we use with our EMS agencies for EMTs and paramedics. So it's opioid education and naloxone distribution. The inclusion criteria is really broad. We want Narcan to be given to anyone and everyone. So really, obviously, we give it to people who have overdosed on opioids, but also we want the crews to start noticing patients who are at risk for opioid overdose, whether that's prescription or illicit. So whether they are going through their pill bottles and see several MMEs, lots of opioid pills that they have, or they see evidence of illicit use, we want people to get a kit. We also are having our fire departments, people can just walk up to the fire departments and get naloxone as well. And we've done press releases, so it's in the newspaper. We've had news reports on local TV stations. Then every now there is an opioid consortium in Santa Cruz County who's quite active, and they have events throughout the city, and we'll have our firefighters there giving out naloxone. So we really want to be visible. We really want the community to know that we have this resource. And we're getting it to people who are not patients as well. And I got some advice from Dr. Mercer about that. With Project Friend, it sounded like there was quite a few people who just walk up to the ambulances and ask for naloxone. How do you record that if it's not a patient encounter? So we have a different way for recording those. Anyway, if you want more details on that, we can get into it. But here are the orders. So if someone meets that inclusion criteria, we give them a kit. We have 2 different kits available. When we first started, we were getting the intramuscular kits. So we were for a local harm reduction agency, which is harm prevention work, so the biggest one in the state. So they would give us these little brown bags, and inside would be 3 vials of naloxone, 1 dose per vial, and 3 syringes. And we'd have the crews show the family member or the person how to pull up 1 dose into a syringe. So they'd have 1 preloaded syringe ready, and give them a little sheet about it for future reference. More recently, we've been able to get the intranasal kits, which I think has been really helpful. It's much easier for people who do not use to understand. And additionally, as we're not really seeing a whole lot of IV use, we're seeing much more ingestion and smoking. Fentanyl, people may not know how to use syringes. It's not IV heroin use that we're seeing here. So I think the intranasal is probably better for our population. It also seems like there's a little bit less pushback about giving out intranasal naloxone than giving people syringes. Even though you can very easily make the argument that it's good to give out syringes for public health reasons, when you're trying to convince a population who's a little bit maybe more skeptical of this program to begin with, it's helpful to have intranasal kits. So we also teach the crews how to do overdose recognition response training. So obviously our crew members know how to respond to an overdose and how to recognize one, but how do they teach a bystander? We use an acronym called BLUE. We want it to be simple. And then we have the crews call HOPE, which is our local peer recovery support specialist team. So for every single overdose, let me backtrack a second. If they're just giving out Narcan to someone who comes to the station or to a bystander, we do the overdose education training, give them the Narcan. But when they're responding to an overdose, we want them to call 100% of the time to call our peer recovery support specialists. So it's an opt-out. I thought that was important to do opt-out instead of opt-in, because during that whole, you can imagine the scene where someone has been revived. Maybe it took a few doses of naloxone to revive them. They're sort of out of it, or maybe they're going through withdrawals. It's not really the best time to get consent to have an organization reach out to them. So we just say it's an implied consent, they can opt out, but it's not, they don't have to opt in. So EMS calls HOPE. Of course, they only work 9 to 5. So if it's outside of those hours, they leave a voicemail. We've tried to make this process as HIPAA compliant as possible, so they don't mention the word overdose, since there are some special regulations around privacy when it applies to substance use disorder. That being said, I don't think fire departments fall into that. Those regulations are more designed for OTP, opioid treatment programs, such as methadone clinics. So we don't really have to be too careful about privacy, but we are still doing it to make everyone feel more comfortable with the process. So our firefighters call Hope. They leave a voicemail saying, hey, this is Nogales Fire. I responded to this person, this address, this phone number. They don't say why, it's just implied. Hope knows that if Nogales Fire is calling, this is the reason. And then within 24 hours, a representative from Hope, a peer recovery specialist, shows up and tries to meet this person and engage them. They could link them to Matt directly. They can give them a ride to Matt. They can get an ID for them, because at opioid treatment programs, you have to have a recognized ID. Lots of people don't have those. So the Hope outreach worker can take them first to get their ID, then take them directly to the MAP facility if they're interested. We initially thought about doing a treat and refer where we would take directly to the methadone clinic, but the clinic has fairly limited hours. Dosing hours are from 4 a.m. to 11 a.m., something like that. And outside of those hours, it can be telemedicine, but there's not always someone at the clinic. So that became a problem. And then there's also a federally qualified health center that offers buprenorphine. And so we had two different, I could say, competing clinics. And I think for an EMS protocol to be effective, you have to just choose one. You can't have too many options. You have to make this streamlined. Crews have other places to be. They have to get back to the station. They have other calls, especially in rural counties where you may not have very many paramedics on duty at once, maybe just one or two. So that was the reason we decided to use a peer recovery coach, because they could decide which clinic might be best for this person. Would a federally qualified health center be better for them? Would Bupe be better for them? Or they benefit more from methadone? So this has actually worked very well. And it's been nice that it's a small county, because I can follow up. There's one person at Hope who's sort of in charge of all this. He knows the outcomes for every single patient. We talk monthly and go through and see who's been engaged and who hasn't. Some challenges have been that some people give fake phone numbers and they're not at their home addresses, so they can't be found. But we have had people who have gone to treatment, not necessarily within the first month, but within the year. They seek out treatment later because they know it exists. Moving on. So here's the data we've collected from 1 year. So we started in October of 2020, and this is the data from October of 2021. Most of ours, and this is the data from just the overdoses. So I go back through the EPCRs. I look at everyone who has primary or secondary medic impression is overdose, and then I include all the opioid overdoses. And this is just for Nogales Fire, since they have so many more calls than the other agencies. So the majority are men, and they're fairly young. The median age is 26.5 years. So these are people who have lots of quality adjusted life years ahead of them, and making an intervention to prevent fatality can have a huge impact. We know that of patients who EMS gives naloxone to for an overdose, 10% of them die within the year. So these are young people. We want to intervene. We have an opportunity to make a big difference here. More than half of the overdoses occur at a private residence, which is, I think, an indicator that's so important to get family involved, because lots of times it is family and they don't always know that their loved ones are using, but if they had a naloxone kit, they could respond. The majority of cases, police was already on scene. When an overdose goes through dispatch, through 911 dispatch, police are automatically sent there, and they usually get there before fire. And lots of the time, they have given, almost half the time, police have given naloxone already. More recently, I've noticed that several doses of naloxone are being used before a patient is no longer overdosed. So I'm assuming that's because of fentanyl. So about 1/10 of patients get naloxone given by family members or friends before EMS arrival, almost half by police, and a large percentage by EMS. And when I go through records, it looks like EMS is giving it appropriately. They're giving it for people who do have respiratory depression, hypoxic. About 1/3 of the patients refuse subsequent transport to the emergency department, which is another reason why it's so important that we're giving out the naloxone kit and making that contact with Hope right then and there. And even when they do go to the emergency department, there's only one in the county, and they do not offer MAT. They do not give out naloxone. I don't think they refer even to the methadone clinics. They don't have bupe available in the hospital. It's not on their hospital formulary. So I don't even think it's very helpful when our patients are transported to the emergency department. So when patients ask not to go, I sort of encourage our medics to agree with them and not give them a hard time about it, because when I've talked to patients who have been transported to the ED, many have an unfavorable experience. So I think just being referred to an OTP and getting Narcan is probably the best course of action. And like I mentioned, the majority of these overdoses are with illicit fentanyl. Does anyone have any questions about this before I move on to the history of addiction and EMS?
Thanks. Thanks, Dr. Glenn. That's really a wonderful description of both the program and the QI. I think if you want to speak a little bit more to how you're QIing or giving that feedback to the teams of what you're discovering as you're monitoring the situation, and that interesting comment about the ED providers or the ED experience for patients, and how that feedback gets to the hospital.
Those are both really good questions. Yes. So as far as the feedback, I review the overdose calls every week. We usually have a couple per week. And so I review those on Fridays and send the information to the EMS captain at the fire department, who then sends it to the crews. So that's just individual feedback. In addition, we have quarterly QI meetings with the Santa Cruz fire departments, and we go through this protocol specifically and tell them this quarter, 70% of patients got naloxone and 50% got referred to Hope. What can we do to get higher? We've noticed that to improve the numbers, we have to have in-person trainings. So a year ago we did this, and we just did again last month, a sort of a refresher training where we have Hope come, we have representatives from the methadone clinic come, and we have representatives from the federally qualified health center come. If I'm able, I come, or I show a video with our protocol. And then they sort of play through a case. We have a medic and an EMT, we have a representative from Hope, and we have someone pretend to be the patient, and we go through the case. And after we do these real-time refreshers, we find that the numbers, the adherence to the protocol really goes up, and the crews really like it too. We've gotten really positive responses. There's been very little pushback about doing this. About the hospital, we keep trying to engage with them. They sometimes come to our EMS meetings. There's been some turnover in hospital leadership, so I'm hoping with new leaders that might change. We just keep trying to engage. And then, as I mentioned, there's a big opioid consortium in Santa Cruz County, and the hospital attends those consortium meetings as well. So they're getting this feedback from multiple players. It's not just me or us who's saying it, but the methadone clinic is trying to get more involved. Hope is trying to get them more involved. The FQHC is trying to get them more involved. So everyone's trying to do it. And I think they're coming around. I think they're showing a little more interest. But I think it's hard because they're short-staffed, and with the pandemic, they've got other maybe bigger problems going on. So it's been difficult. I offer to go and do lectures to their ED providers about starting MAT in the ED. So I'm hopeful that it will change.
Thanks so much. We'll enjoy asking more questions in the panel discussion. Thanks.
And I have if you were 5 more minutes or so, if you guys want to hear this little bit of history. Yes, that's great. All right. So I've been doing a lot of research into the history of addiction treatment in the United States. And more recently, I found the intersection with EMS. And it seems like one of the first major EMS agencies was also the first to use naloxone. So you've probably all heard of Nancy Caroline, who wrote, the textbook, or one of the textbooks. So back in the 70s, I guess it was late 60s in Pittsburgh, a former governor, former mayor was speaking on stage. He collapsed, I think, cardiac arrest. At the time, there was no modern EMS system. He was just thrown in the back of a paddy wagon, taken to the hospital, and the anesthesiologist named Peter Saffer was there. It was too late to revive him at this point. He was pronounced dead, and Dr. Saffer was upset by this. He's like, we need a modern EMS system. We need to start training people how to do cardiac arrest care and, modernize what we're doing in the field, take it away from the morgues and the police departments and put trained providers out there. So he developed a paramedic program. And it wasn't just any paramedic program, but they went to a predominantly Black neighborhood in Pittsburgh, and they wanted to train people from that community to make it more of a civil rights project as well. So using one of the first EMS agencies was born out of civil rights and out of anti-racism movement. So the first agency was called the Freedom House Medics. They really grew in their training and their expertise, quickly becoming one of the best EMS agencies in the country. Nancy Caroline became their medical director. They applied for a federal grant to sort of show the rest of the country what EMS can do. And when applying for this, they create a huge mass casualty drill, and just to show people, look, this is what modern EMS can do. This is why we need healthcare providers in the field. Anyway, they got the grant. There were some racial politics in the city. Pittsburgh didn't really want this organization to receive the funding, but getting back to addiction, they were the first documented EMS agency to use naloxone. Before, it was something just kept in the hospitals, not out in the field, but they were using it because there was a heroin problem in the neighborhood, and they were responding frequently. And then moving on to one of the first times that Narcan got into the hands of lay people and users. I talk about this program, how we're giving out Narcan to lay people to use. That started in the 90s at various parts of the country, not really in communication with each other, sort of concurrently. One of the places where it started was actually rural New Mexico, up in northern New Mexico, where there was sort of this Wild West town south of Santa Fe. And the medics would come in, and this wild town was also cultivating large crops of cannabis on the hillsides. The paramedics came in off duty, said, hey, we want to trade you some of what we have for what you have. And the people in this town asked for Narcan. They said, hey, you guys, we've heard of this stuff that you use to reverse overdoses. We'd like to have it because it takes a long time for EMS to get here, 30 minutes or so for a call. And so that was one of the first examples of lay people getting naloxone. Another was from a paramedic in Santa Cruz, California, who wrote a zine about how to use Narcan and what it was. And I just think that this is a really cool history, that EMS and addiction have been linked since the very beginning, democratizing Narcan, democratizing the treatment for opioid use disorder. And civil rights has been a part of it this whole time as well. Anyway, that's the end of my presentation. Thank you all for your time.
Okay, thank you so much, Dr. Glenn. And we're going to move on in the discussion. I know that you'll be stepping away, but joining us back for the panel discussion. Thank you. Lots of really great food for thought. And I think our next panelist is Dr. Charlie Murphy from the University of California, San Francisco, in the emergency medicine department, where he is currently serving as a research fellow. And his area of focus has been on emergency department management of substance use disorder. And today he's joining us to speak about the emergency department initiated Naltrexone for alcohol use disorder. So I will turn over to Dr. Murphy to share history and background on this program and the specific program at UCSF as well.
Okay, thanks everyone. Thanks, Mary. Happy to be here. So yeah, I'm here. I'm going to talk about sort of a pilot study that we ran at UCSF that was investigating ED-initiated extended release naltrexone for alcohol use disorder. And I'll give just a brief background on sort of alcohol use and this drug, but I wanted to share the, our results and experience with this program. I don't have any financial interests to disclose. And then, Mary sort of introduced me, and working at UCSF in the emergency department. I did my research fellowship there for 2 years after graduating residency. And then I work part-time in the ED there and do my research there. And then I also work in the community over at Eden in Castro Valley. So a bit of background, alcohol use disorder it's common and costly. Over the past decade, there have been pretty substantial increases in emergency department visits and healthcare costs also associated with alcohol use disorder. And, to the best of my knowledge, sort of best estimates are that, maybe 15% of opioid overdoses also involve alcohol co-ingestion. So there's sort of an intersection between the two as well. Obviously, many patients have sort of comorbid substance use disorders with a variety of substances, including alcohol. Optimal treatment for alcohol use disorder is, sort of community support, behavioral and pharmacotherapy interventions that are tailored to the individual patient. Naltrexone has been approved for alcohol use disorder and opioid use disorder. And it's been FDA approved for decades in 2 formulations. There's a daily oral tablet, and then also an extended release injectable, which is marketed under the brand name Vivitrol. And that's a once monthly injection. So some of the motivation for this trial was that, medication assisted therapy for alcohol use is underutilized for everyone. But until recently, I would say that its use in the emergency department was like almost non-existent. I think during my training, I don't think anyone ever suggested prescribing it. And there's been almost no published research on it until sort of the past few years. There have been a variety of programs, I think, that exist through counties and that are kind of in like the gray literature, but not much actually like sort of published in academic journals anyways. But so I think that it seemed like something that was worth trying to study. The ED, I think, as we all know, serves as a primary point of contact with the healthcare system for a lot of patients, and probably sort of disproportionately higher number of patients with alcohol and substance use disorders. And obviously, we feel that the visits could probably be leveraged as a teachable moment to intervene on someone's use disorder. And there's been, some success and some publications relating to, ED-initiated MAT for opioid use disorder. And so we thought, it was worth trying to design something to investigate alcohol use disorder. So just a brief overview of the design. The population of interest was basically emergency department patients with alcohol use disorder, who could either sort of self-identify or would be identified by the provider who was caring for them. The intervention was a monthly injection of extended release naltrexone, the first dose of which was given during the ED visit when they were enrolled. And then they were also given the option of having case management services for 12 weeks, which were provided by sort of a research case manager who was both sort of the research coordinator and also provided case management services to those who were interested in them. And patients could choose to have them or not, and the services that they received was sort of tailored to them based off of their individual needs. This was just sort of a pilot feasibility study, so it was just a single arm, and we compared people's drinking behavior, healthcare utilization, and before and after the intervention. We did sort of a structured interview called the timeline follow back to get the alcohol consumption. And then we collected data on ED visits, and then also, feasibility outcomes, like, how many people could we recruit and could we retain them as well. So those were the main outcomes that we were interested in. Eligible people were, of legal drinking age, and we used the audit C to screen people. They had to have an audit C score, over 4, and then they had to report that they were actively drinking. And that all that meant was that they hadn't actually quit yet. So they didn't have to have had a drink that day, but they hadn't actually decided to, stop drinking prior to that ED visit. And then, we did not include, we excluded pregnant patients and incarcerated patients and people who had allergic reactions to the drug. And then everybody had to have liver function tests. And if you had greater than 5 times the upper limit of normal, or if you knew that you had cirrhosis, or we found a documented history of cirrhosis, you were excluded. And then platelets of less than 100,000 were also an exclusion. Opioid use was probably the biggest excluding factor as well, because the drug obviously, is a opioid antagonist, and so can precipitate withdrawal in people. And if you need opioids for whatever reason, it can make it a little bit more challenging to manage pain or have surgery. So anybody who was currently on them or reported opioid use in the past week, and anyone who had a urine toxicology that was positive for opioids and opiates or fentanyl, we tested people for fentanyl as well. They were excluded. Similarly, if you had to have a major surgery in the next few months, you were also excluded. So this is just a sort of a figure going through kind of the screening process and who ultimately enrolled and kind of what happened to them. So we had 179 people who kind of were pre-screened, and that included chart review, and then going to approach the patient if there was no clear reason why they wouldn't be eligible. And then, of those, 88 just had no interest in participating in the study, and 36 didn't want to have any extra blood or urine tests done to see if they were eligible. Obviously this was done during an ED visit, and people may not have been there for their alcohol problems specifically. And so there were some people who didn't want to have anything extra done that was not related to their chief complaint. So ultimately we screened 55 people for eligibility, and we excluded 23 of them because of liver disease, opioid use, and then or need for major surgery. And then there were 4 people who were eligible but ultimately decided that they didn't want to enroll. So that left us with the 32 people who enrolled, and they all got their first dose of extended release naltrexone during that ED visit. And then, of those 32 people, we had 23 who completed the entire 12-week intervention period, sort of per the protocol. We had 2 people who decided to stop the injections, but continued getting case management. And they actually provided complete data for the entire 12 weeks. Both of them were kind of having some side effects, either injection site pain or nausea, in one case where they felt like they just didn't want to be on the injection anymore. And then we had 2 people who missed some of their visits, but ultimately, were able to give us enough data at the beginning and end of the study where we could sort of do a pre-post comparison. We had 3 people who were completely lost to follow-up. All of those were after their first injection, and we just never really saw them again. And then 2 people withdrew, one for sort of personal or unclear reasons, and one because they felt like they did not like the side effects, and then they did not provide us with any data. This is just our sort of summary of like the demographic characteristics and sort of alcohol baseline use of our study population. We collected information on sort of education and annual income, and primarily I would say, sort of summarizing this, is that it was largely sort of middle-aged white men who enrolled, and you can see sort of the median income was around $30,000, and most people had a high school diploma, and then maybe a year or two after high school, but not a college degree. About 2/3 were employed and 2/3 were stably housed. The rest were, unemployed and, experience homelessness. We had a, pretty high rate of sort of serious mental illness comorbidity. About a quarter of our patients had a comorbid serious mental illness, including, suicide attempts, high rates of tobacco use and substance use disorders. Most commonly amphetamines and cannabis. You can see under the sort of alcohol use and quality of life measures that the alcohol use, the audit C scores were, 11 out of 12. So 12 is the maximum, and sort of daily drinks per day. And this is sort of your standard kind of beer, wine, shot of liquor was somewhere around 8 drinks and 8 drinks per day on average over the past 2 weeks. And then these other things, the World Health drinking risk level, those are just kind of like summaries of how much you drink and how that's known to affect your health. But the risk levels go up to 4. And so our median was a 4. So bottom line is that these people, on average were pretty significant drinkers, pretty severe use disorders. And, we measured alcohol-related life problems on this sort of 45-point scale. And the median was 26, which would be sort of count as a high level of alcohol-related life consequences. We also kind of asked a single question screen for quality of life, which was on this 7-point scale. And I'll show that in a little bit. But sort of 4 is in the middle, and that's like life is so-so, and 1 is life's terrible. And the median was sort of somewhere in the middle. I showed the before and after here. Largely, the people who enrolled and the people who completed were pretty similar. I would say that it seemed to me like, there was the amphetamine users were maybe a little bit more likely to drop out. That wasn't statistically significant, but I did notice that. And then, as far as our alcohol consumption measures, we saw really substantial decreases in alcohol use. Our median drinks per day dropped down to 0 over the 12-week period for people who are enrolled. This is a plot of sort of the rolling median of the daily alcohol use for our participants. And this is, essentially at week 0 here, that's baseline. And then the shaded area is the interquartile range. And then everything after that includes everything that came before. So you can see that, by 2 weeks, people had really reduced their drinking, and that continued sort of over the course of the study. The table down below sort of shows the number of people who were contributing at each measurement point. So as you see, we sort of lost a few people in the middle, and then a couple of people kind of came back at the end. And so pretty impressive reductions in drinking. I think honestly, like much more so than I was anticipating. Really pretty remarkable, but hard to say, how that would compare to, say, a placebo or an oral, because we don't have a comparison group. But in some ways, I would say, does it really matter as far as these patients are concerned? Probably not. They had a pretty substantial improvement in their drinking behavior. This is some other data that I looked at as far as the effect of the case management. And, overall, if you kind of look at the entire group, it seemed like maybe case management didn't have an effect, but there was sort of evidence of an interaction between the housing status and the effect of case management. And so it seemed like our patients who did not have stable housing really benefited from the case management in terms of the amount of alcohol they were consuming compared to those who were stably housed. And that's not entirely surprising, really. But it was interesting to see sort of how big of an effect it had for those who were experiencing homelessness compared to those who were not. So then this is just sort of showing some of the changes in the on that 7-point quality of life scale that I mentioned. So, 1 is life is very distressing, and then 7 is life is great, like couldn't get any better. And then in the middle is sort of so-so, which is 4. So the red circle sort of shows kind of the spread and centers around where the mean was before, and then the black circle shows after. So, we saw sort of greater than a 1-point shift here from sort of not so great to doing pretty good. And that really correlated also with this reduction in alcohol-related life consequences as people's drinking behavior changed. So that was encouraging to see that not only did drinking change, but people felt like their lives had actually improved. This is just wanted to show sort of the way that we measured alcohol-related life consequences. So, people would have a sense of like what that meant. And it's basically just 15 questions. And they ask, in the past 3 months, how often you've been unhappy because of your drinking, and how often has it caused you to not eat properly, or you failed to do what was expected of you, you felt guilty, you took unnecessary risks, that kind of thing. And then how's it affected your physical health and money problems, physical appearance, social relationships, things like that. And then have you had, an accident that was related to drinking or being intoxicated? And so that's the 45-point scale that we use to measure the alcohol-related life consequences. And we saw scores go from a 26 down to a 9, which is really substantial. So sort of a summary of the findings, initiation of the extended release naltrexone and case management for alcohol use disorder, we found that was feasible in an emergency setting. We had greater than 80% retention over 12 weeks. And, we recruited about 1 to 2 patients a week for about 6 months, despite sort of pandemic conditions and the winter surge and crossing major holidays. So that was encouraging. I think that there was an interest in this from our patients, and they seemed to stick with it for the most part and follow up well. So that was great to see. The intervention obviously substantially reduced alcohol use and improved people's quality of life. And as I mentioned, there's reasons why that might be from a research perspective, as far as placebo effect and selection bias. So, might not be the same if you just tried to give this drug to everybody, but by the same, on the other hand, I guess, there's clearly a group of people for whom, an intervention like this, I think could be beneficial. Case management might be most impactful for those experiencing homelessness and perhaps less so. For those who are housed, it's a little bit hard to say. The numbers are pretty small here, but it's certainly something to be explored in future research. And then, other things were sort of just like planting the seed. We had a lot of patients who we offered them enrollment. They sort of initially said no, and then they would actually like call us back a day or 2 later asking like if they could get help or get into the study, and we're actually interested in seeking treatment sort of a day or 2 after we had spoken with them about their problem. And that was actually really nice for me to see as an emergency physician, just that, I think a lot of the time people are discharged and when we don't necessarily see them again unless something bad has happened. So we don't really see our successes, but we see our failures, like particularly when it relates to substance use disorders. But like people can change, and what we say to them, I think can help at the very least start that process. So I think that was a really key takeaway for me. This is an EMS group, and I didn't do an EMS fellowship. I haven't been really involved in sort of pre-hospital medicine, but I think particularly my experience in San Francisco has been one of EMS being highly involved in this patient population. They're a key stakeholder in sort of development of like clinical pathways and expanding access to treatment. And I think that we had some overlap in our patient population with those that are would be served by programs like EMS 6. And so potentially there's a role here to formalize sort of AUD interventions in addition to all the other things that are being done. Obviously identifying people who can benefit from treatment and planting the seed, with sort of brief discussions, especially people who aren't being transported to the hospital. I think that what we as emergency providers say to patients can help them on in their thinking, get them thinking about their use and maybe get them more ready to change. So I think that's a key role. And then obviously potentially as providers of MAT or linking to care, or there's a lot of really innovative stuff that y'all have been doing, and I certainly see that as a possible future as well. So that's all I actually have, and I'm happy to take any questions. Unfortunately, I'm not going to be able to be at the panel. I have another meeting commitment, so I apologize for that.
Thanks so much, Dr. Murphy. So as a reminder to the attendees, if you have questions, please do put them in the Q&A section and we'll be sure to relay them. I do have a couple of follow-up questions for you. If you can kind of share with the group, and I'm sorry if you already mentioned this, but has this program continued in the ED since it was studied, and have there been other kind of iterations on it or changes for sustainability?
Yeah, so the program had to stop when the study finished for a time, and that was so we could actually get the medication on formulary, which it wasn't when we first started. It was only available through the study, but we now have it approved by P&T, and so actually I have a meeting this week to kind of formalize the process of how this will be used in the emergency department. So, my hope is that by the end of the year, we'll actually be back to being able to give this in the ED. And obviously, I know at San Francisco General they're doing it, and Highland they're doing it. So it's I think locally we've got a lot of people doing it, and it's nice that UCSF will be joining that. I do think that we've been prescribing, more oral naltrexone in our department sort of since this happened, and that's been nice to see.
Great. And there's a question in the chat from Dr. Glenn about how did you get your hospital to support extended release naltrexone?
Yeah. Well, this was actually I would say that our department was really open to it. Obviously, we've had a lot of people working in the area of alcohol and substance use recently who are on this meeting, and so had a lot of departmental support from the institution of UCSF. It was actually a little bit more challenging, kind of because this was a research study dealing with the IRB, and really just had to be a lot of open dialogue about how we were going to do this safely. Because look, there's a lot of unknowns in the emergency department, and we don't always know if people are on on opioids or not. And I mean, we were enrolling people who were, maybe a little intoxicated. And so we had to have sort of structured evaluations to determine capacity. That was all because this was a research study. But so I guess I would say that it was a lot of conversations over the course of about a year, largely relating to how we were going to do this safely and why we thought we could do it safely. And that was a trying time, but I think ultimately was time well spent. And I think that once we really sort of convinced people that, look, we can do these tests, we know these patients, we're able to assess their capacity, no one's going to get the drug if they don't want to, and we'll appropriately screen people for sort of contraindications based off of sort of the FDA approved use. Ultimately, people thought, okay, yeah, you can do it.
Thank you so much. And this is, here's a question. Did you find that participants also reduce their use of other substances? For example, you said opioids are sometimes co-ingested with alcohol.
Yeah, so opioids are one that I can't speak on because people weren't allowed to be on opioids or when they started the study, but other substances, yes, in general, the people reduced not only their alcohol use, but their other substance use as well. And again, with the amphetamine users, it did seem like there was maybe a trend to dropping out more. So it's possible that our results would change, like if we had complete data on that. But certainly things like cannabis use decreased a little bit, tobacco use decreased a little bit, and so we did see some reductions in drug use, though not as significant as the alcohol use in general.
Thanks so much. And this is really a great segue and a great talk to have before our next speaker. I was struck by that interaction you showed around case management, having much more of a stronger impact for those experiencing homelessness. And really just kind of further evidence of how housing can improve is sort of the primary treatment for or assistive treatment for a lot of the therapies that we're talking about here, but also just in health in general. This is such a game changer to have a program like this available in the EDs. I'm thinking back to the early days of collaborative case management for pre-hospital care plans for the managed clients by EMS-6. And, for some clients, part of the care plan was re-enrolling people into their Naltrexone program or making sure they made their appointment. But to be able to have this therapy available in the ED would really assist with that warm handoff ability. But our next speaker is Captain Michael Mason of EMS-6, the Community Paramedicine Program, and now the director of the SORT program, the Opioid Response Treatment Program with the Community Paramedicine Program in San Francisco Fire Department. And would love, Captain Mason's going to primarily speak about the SORT program in treating opioid use disorder, but also can, as sort of a segue, if you can share some observations, thoughts, and progress that's been made by the EMS-6 side of the community paramedicine program around managed alcohol use in San Francisco, which really evolved out of response from the shelter in place orders that have affected a number of our shared patients who are EMS-6 clients as well. So thank you, Captain Mason, for what you're about to talk about, and we are looking forward to learning from you.
Thank you, Dr. Mercer. And let me just throw it out there, not to correct you, I manage the fire department's side of the street overdose response team. I'm the fire department program lead, but it's a collaborative effort with our partners at Department of Public Health. So I always—
Yes, apologies for misspeaking.
Yeah,
thank you.
I got to let everyone here know I'm definitely not in charge. Dr. Mercer I think I will speak to street overdose response first, and then I have a few slides to share on the managed alcohol program. So first, thank you for having me here today, folks. I have no disclosures. My name is Michael Mason. I serve as a community paramedic captain with the San Francisco Fire Department. I'm in our community paramedic division. I've been with the department for about a decade, and seeing Dr. Glenn here earlier was wonderful because she helped with one of the community paramedic class I was in, which was the first one here in San Francisco, and I have a feeling one of the first ones in the state. And I'll speak a little bit later about community paramedicine and their expanded scope. But for now, let me share my screen here.
Oh, there you go. Perfect.
Thanks, guys. Okay.
And if you can bring it into the slideshow, that will help, I think.
I got it. Okay. So I'm going to start this presentation sharing some gratitude. Preparing for today, I was looking at last year's talks from the symposium, and Dr. Gene Hearn was presenting and expressing his gratitude to providers. So it feels like a little bit of a Russian nesting doll here. Dr. Hearn has been wonderful support with our program. And I want to repeat that expression of gratitude and all the providers that have come before us, leading the way in this sphere of EMS-based early interventions, especially with opioid use disorder. Big shout out to Dr. Barry Zevin, one of our fearless leaders, as well as Dr. Hillary Kunins, who will be presenting next. Dr. Kunins doesn't know, but I completely stalk her online and on the radio and watch everything she says, and repeat some of the smart things she says, and makes me look better. So big shout out to those folks. Okay, I'm here to speak, and excuse the background noise. I'm in a fire station, and we are testing. We've chosen this moment to test our dispatch, our new dispatch system. So you'll hear some real fire department action in the background. So I'm here to speak about the street overdose response team. I'm going to refer to it as by its acronym, which is SORT. It is a true collaborative effort between the fire department's community paramedic division and the Department of Public Health, specifically their street medicine team. Now that said, this is a true collaboration. I'm going to be presenting this through a fire department, through an EMS lens, and I won't, although I'll tell you some of the DPH and some of what my DPH colleagues are up to. I'm not in a position to really speak well for them, and I know Dr. Hillary Kunins will have some, I'm assuming or guessing she'll have some more information on that side. Okay, so presentation is going to be in 4 parts. I'm going to start with what I call the data narrative or the data story behind this program and the EMS programming. Why EMS? Why community paramedics? Why are we well positioned to be involved in responding to folks with substance use disorder and opioid use disorder? I'm going to give you a specific overview of SORT operations. What are we actually doing? What are we physically doing in the real world to change folks' outcomes? And lastly, we have data from our first 3 months of operations. So we'll kind of give you the initial sneak peek of what we're finding so far. Okay, so our data narrative. We're going to go over some things that many of you already know. If there's some folks here watching from outside of San Francisco, you'll learn a little bit about San Francisco and California. But for the folks here based out of SF, this data narrative portion won't have anything you don't already know, but it may, you may, at the end of it, there's going to be a few things that you may not already know. So what you already know, overdose deaths are on the rise nationally. Breaking news, right? Last year, 30% rise from 2019 to 2020. Overdoses are on the rise here in San Francisco. San Francisco, as of 2019, was out of all metropolitan areas nationwide, had the 5th highest overdose rate per 100,000 residents. We have the highest overdose rate by far in the state of California. And overdose deaths are on the rise here. So this is stuff you already know. Why? Well, I can't speak to broad policy and socioeconomic factors that are impacting drug availability and consumption. But one thing we do know for sure, fentanyl, right? UCSF research shows that the presence of fentanyl increases your risk of overdose death by about 3 times. These are some photos of fentanyl I took about 2 weeks ago while engaging some of our clients. So here we go. Okay, so here are some things you may not already know. The overdose epidemic really reflects larger socioeconomic and racial inequalities, right? So 6% of San Francisco residents are Black. However, 25% of overdose deaths are people of color. Less than 1% of San Franciscans are unhoused or homeless individuals, but they represent 30% of all overdose deaths. 10%, actually less than 10% of San Franciscans live in the Tenderloin and Soma neighborhoods, but 40% of overdose deaths are occurring in those geographic areas, right? So there's real large socioeconomic and racial disparities that we're seeing in this epidemic. Here are the last 3 key data points that I'm going to give you as part of our data narrative, as part of our data story, and I'll have the soup pot picture come up next. And these ones I want to burn into your brain. In 2020, 712 folks died of drug doses here in San Francisco. We worked with our office of the medical examiner. We got those names. We ran them against ambulance transport records from the fire department, and we found out that about in the 2 years prior to their death, the San Francisco Fire Department's EMS division had contact with a little less than 50% of folks who would go on to die from drug overdoses. So it turns out that our EMS division is actually engaging a very large proportion of folks prior to their death. A non-fatal overdose is one of the strongest predictors of future overdose mortality risk. And so let's keep that in mind. Lastly, now this one's a trip. Less than 1% of the unhoused folks who died in 2020 were actively taking buprenorphine. Okay, so we have a lot of data. This is how I think about it. With it all goes into a pot. What does it mean if we simplify it? We should probably aggressively engage individuals who experience non-fatal overdose. That's what all this data narrative means to me. Okay, so why EMS? Why EMS involvement? Well, I'll keep this quick, or I shouldn't say I'll keep it quick, but it's a simple answer, right? EMS personnel respond 24/7, 365. We don't have service gaps with our programming. Paramedics, the 911 system is always active, so we're always available to respond. We're already engaging this population, right? For decades, EMS and 911, this is what we do. We respond to overdoses, and our data shows that we're actually already engaging the folks who are, 1, at highest risk of future mortality, and 2, we're also actually engaging the folks who will go on to die, or retrospectively, we found that out. Trajectory of care, right? We can begin trying to adjust people's I think about it as adjusting their future, but adjusting their trajectory a little bit right at the scene. We can start that immediately. Community paramedicine and community paramedics have an expanded scope and an expanded knowledge base and increased training. And so a standard paramedic here in California, if they arrive in the ambulance to see an overdose, you either stay there, you sign out a waiver, or you come to the hospital. Community paramedics have a little bit more wiggle room where they can direct you to alternate destinations. They can bring you directly to urgent care, directly to treatment programs. They have a larger resource pool to draw from, and we can begin that trajectory of care immediately. And one of the things we can do is just helping a client choose which hospital to go to, right? And we all know the different hospitals have different levels of service, have different levels of buprenorphine availability depending on the day of the week. And so something as simple as just helping the ambulance crew decide on a hospital destination can start impacting that individual's care right away. Lastly, our community paramedic division has forged successful partnerships with our Department of Public Health in the past. I got to give a big shout out, SFDPH rocks. And so we've worked successfully with our Department of Public Health in the past. We know the players here. We have longstanding relationships. We've spent many years establishing memorandum of understanding for data sharing. So we have access to our integrated health exchange. And so we are well positioned to play a role in this program. That's the big key takeaway, right? The fire department here is well positioned to assist with that initial response identification and engagement of individuals who have survived an overdose. Okay, so we have the data narrative. You know why I think paramedics and community paramedics should play an important role in this. What are we actually doing? I'm going to be a little bit of a ham. I'm going to play a short clip here. We had a reporter with us, and this will show myself and nurse practitioner of Department of Public Health, Kevin Legore, driving around, give you a picture of what we look like.
Is poisoning parts of the West. Last year, San Francisco saw twice as many deaths from overdoses as from COVID. NBC's Jacob Soboroff looks closer in our Sunday Focus.
I'm riding with the San Francisco Fire Department right now, part of a new unit that responds to opioid overdose calls. There were more opioid overdoses in San Francisco than COVID deaths in 2020. This unit's meant not just to save lives, but to stop this from happening again. The city of San Francisco has been hit so hard by overdose deaths, it now has a new unit devoted to harm reduction. I rode along with Captain Mike Mason of the fire department and Kevin Legore, a nurse practitioner.
This is our guy.
Thanks all. I couldn't help but share that. If I have one tip from riding with that reporter, it's dry shampoo. So continuing on, what is our response, right? What's the goal? Reduce the overdose mortality of the highest risk groups, right? How do we want to do that? We want to actively identify and engage individuals most at risk for overdose death, focused on the unhoused population. We'll get into exactly how in a bit. Offer treatment on demand, including buprenorphine, and coordinate follow-up care and access to treatment and services. We started on Monday, August 2nd, so about 3 months ago. Now, what exactly does a street overdose response team look like? Well, it all starts with a 911 activation. We have 2 branches of this program. We have response teams, which are community paramedic led teams with a community paramedic and a peer support specialist. They respond in real time to 911 activations. We have some follow-up teams from the Department of Public Health, and I'll talk about them briefly in a moment. But it starts with 911 activation, right? Standard ambulance. In addition to this ambulance, you get a community paramedic. What's their job? Identify the individual, right? I tell my community paramedics, if that's all you do, if all we get out of this engagement is identify this person, we're getting them on that high risk registry, we're scheduling follow-up care, we know we're putting up that red flag, that's half the battle. But beyond collecting the information, identifying who it is, begin the relationship at the scene. A lot of these folks are unhoused. If they've overdosed, they frequently have received bystander Narcan. We are restocking bystanders with Narcan with our Project Friend Narcan. We're collecting data about where the overdose occurred, who the Narcan, was it bystander Narcan, was it EMS Narcan, EMS administered Narcan? So we're collecting that. We're beginning that treatment trajectory. We are asking questions about if this person is individual, is interested in medication assisted treatment. And we're starting with the 5 outreach offerings, which is a little bit of a marketing term I like to use, and I'll get into that later. So far, we found out of overdoses that are occurring that our team has attached themselves to, 87% are transported to the hospital, 12% remain in the community. For folks watching this presentation right now that are ED-based or hospital-based providers, just a reminder that there's a lot of folks who are overdosing out there that you never see. And so that is a big key component for this program, that we are able to engage those folks who don't come to the hospital, who decline ambulance transport, who have overdosed, received bystander Narcan, and are walking away from the scene. Now, here's a big love here and a very pioneering move. the encounter that is logged with a custom internal fire department database by our community paramedic. Every day, our encounters, the folks that we see, the folks that we engage, are automatically transmitted to our DPH partners. So this encounter information goes two places. One, it's automatically imported into Epic, which is our central health information exchange here in San Francisco. And two, when our DPH partners on the follow-up team show up to work tomorrow morning, they have a spreadsheet and they know exactly who we saw in today's work, and they know exactly who to follow up with. And here's one of our fearless leaders, Dr. Barry Zevin. And I have that time symbol there because the follow-up team's work is time sensitive. Recent study came out of Massachusetts tracking, it looked retrospectively at folks who died from drug overdoses, and it looked backwards at their most recent non-fatal overdose. Of the folks that would go on to die, 5% died within 24 hours of their last non-fatal overdose. 20% died within the month of their most recent non-fatal overdose. So we use that expression a lot in medicine, that time is tissue. I mean, in this case, time is mortality. And so it's key that not only do we do that initial engagement, but we have a time-sensitive follow-up team that treats that urgently and treats that engagement window and that red flag for mortality gives it the urgency it deserves. Okay, so we already went over some of the response team. I want you to look down here at the list, the 5 outreach offerings. This is what a community paramedic's doing on the scene of every OD. We're offering education resource guides. This hasn't really existed, especially in the street now. Hi, you just suffered an overdose. Even if you never want to talk to me, I'm never going to see you again, you walk away, let me at least give you the map and the guide that says, where can you get help? Where can you find harm reduction materials? Where can you access safe syringe sites? Or if you're ready for treatment, where can you come for treatment, and what DPH resources are there? Here's that. We give folks harm reduction materials in the form of fentanyl test strips. As we all know here, we're seeing a lot of accidental overdoses when folks are unintentionally ingesting fentanyl. 3, Project Friend Narcan Rescue Kit, yes. 4, an offer of congregate shelter. That's something that's very unique to our community paramedic division here in San Francisco, that an encounter can begin with a 911 call and end with a shelter placement. We have pre-existing relationships with our Department of Homelessness and Supportive Housing. Our division gets a daily allocation of shelter beds. We want to do everything we can to change your trajectory. If you are unsheltered, if you are unhoused, unsheltered, sleeping in a doorway, I can't imagine, I think it's very difficult to ask folks to consider starting treatment or implementing successful harm reduction strategies in that context. So at minimum, I want to be able to get folks inside and stabilize them. Now, that also really helps with our follow-up team, right? If you're unsheltered, it's very difficult to find you. But if we can get you in that shelter, that next day, we can continue that engagement more successfully. Lastly, part of our 5 outreach offerings, buprenorphine. Currently, paramedics in San Francisco don't have this in their scope of practice. We will be applying to the state of California for an expanded scope. They're doing this in Contra Costa County already, where paramedics and transport paramedics can offer folks buprenorphine who are in withdrawal after a Narcan associated overdose. Now, the follow-up teams, I can't speak to their work. I got to be honest with you, that's the hard job, right? Responding in real time, engaging these folks. Our response teams will follow them to the hospital. We'll engage with ED docs. We'll advocate for buprenorphine induction in the ED. We work with the substance use navigators. We're often doing warm handoffs, grabbing our folks who went earlier in the morning and bringing them to shelter. The follow-up work is complicated. It's difficult. It's clinically intense, and these folks do an amazing job of it. So I won't speak to that, but we have upstaffed, and the Department of Public Health has upstaffed this program very robustly, and I very much look forward to them sharing this side of the overdose response team in the coming months and years. Okay, so recap, what's our response? We have a real-time response. We're identifying those at highest risk of mortality. Active versus passive engagement. This is a concept I like to push for our folks, is that we come and talk with you, we come engage with you. I don't want to say whether or not you're ready, but we don't wait for folks to seek us out. We find you, right? And there's some what's that, induced demand there, right? We have true treatment on demand, right? You can overdose in the morning at 10 a.m. and you can be in a treatment program by the afternoon. And whether you want to do residential treatment or you want to do medication assisted treatment, we can make both of those happen in true real time. And then lastly, our targeted follow-up care and coordination. What's our ethos? I'm going to share that at the end. I'll keep you hanging. All right, I'm going to share a little bit of what we found so far in our first 3 months of data. Client characteristics are pretty much what we expect if we were to look at the Office of the Medical Examiner here in San Francisco. If you were to look at their overdose report for the year of 2020, so far our client characteristics pretty much mirror that report of overdose deaths, characteristics of folks who went on to die. One thing it appears that we're doing so far is we are engaging unsheltered folks, unhoused folks at a higher proportion. And I think there's a variety of reasons there, but I'm actually happy with that we're engaging that population at a higher proportion, because that is definitely one of our target populations that we're trying to reduce health outcome disparities within. Lastly, some gender information here, about 75% male. Okay, so here's the interesting data, more interesting data. 71% of our clients we managed to engage at the site of the overdose or in the hospital. So about 50% of the time, our response team makes it to the scene of the overdose and they're engaging that person when they're in the back of an ambulance or they're remaining in the community. If we can't make it to the scene, right, we only have one response team at present. We'll have 2 response teams up and running next year. If we can't make it to the scene, they'll coordinate with the medic unit and they will meet that person in the ED and engage them there. This is a number that I'm very interested to share, and I'm very curious. I'd be very curious to receive some feedback from this group. But one that I'm pleased by. So out of so far the 226 encounters we've had where there's been a confirmed OD, 22 of those have resulted in buprenorphine starts. And that means it either started in the ED or by a DPH provider on our follow-up team who met the client in the community, met them at the shelter, or met them in the back of the ambulance and gave them a prescription or induced them in the community. So we've seen this number hold true for a couple reporting periods. And so I think this will be going up, but so far I'm pleased that this percentage of folks that are ending up on buprenorphine that we engage. And I'd be very curious what this group thinks of that. I'm going to share a quick last clip here and then share kind of what our office looks like and what our ethos looks like.
So I took my Narcan off, stuck it up his nose.
They're going to follow up on the work you did and try to get him into a treatment program.
Hopefully it works, but you gotta want it.
You got to want it.
You gotta want it.
What do you see? Do people want it these days?
No.
I think that this was a certified nursing assistant walking down the street, actually at 7th and Mission, and she saw someone who had overdosed, and she was wearing Narcan on her, around her neck, right? And that's thanks to San Francisco robust Narcan distribution system. She certainly saved this person's life, but as you can tell, she's less than optimistic, and I think that perhaps she's pragmatically optimistic about this. Now, this is the scene that my colleagues and our paramedics are doing several times a day, right? This photo is actually taken by a San Francisco Chronicle photographer looking out their apartment window. They happened to look out their apartment window and saw this scene below. And I think in our work here, I'm kind of doing a kumbaya moment in our collective work here. I think we often have to battle those perceptions of our client population, are they pre-contemplative, or is this working, or is what we're doing working? And when I see this photo and I see the paramedics that work for us, when I see their work, I think we have no choice. We are engaging these folks. We are responding to overdoses. We have to engage them. And when I see someone in a state like this, I believe that I want to give every opportunity to this person available, make every opportunity available for them to have change and have resources and have that opportunity to change their trajectory if they can. Lastly, you know, I tell this to myself and our crews every day. The way things are, it's not the way they have to be. But I very much want to express gratitude to all the other folks who are here, who have come long before me, and who will most likely, perhaps be here long after me, although I'll be here for another couple decades. But deep gratitude to everyone here and everyone here. Please feel free to email me with any questions after this presentation. So that is Street Overdose Response Team. Dr. Mercer, would you like me to share briefly on managed alcohol program?
Sure. I think that would be great just for follow up from while Dr. Murphy is still on, if you would like to share just a little bit of perspective of what's happening there. And we have a few questions to you just to wrap this out before going to Dr. Kunins.
Okay. Here we go. I'm going to share managed alcohol now. Disclaimer, I am not our division's lead on managed alcohol, but I am a ham, and I'll give it a shot to talk on anything. So what is the managed alcohol program? Well, first, let me just tell you what the Sobering Center is. The Sobering Center is a alternate destination site here in San Francisco where acutely intoxicated adults can come off the street and be diverted from going to the ED. Now, this is an expression of community paramedicine, as it's an alternate destination program. Ambulance crews that encounter intoxicated individuals, if those individuals meet a strict set of exclusion criteria, you know, for instance, no head injury, vital signs are within normal limits, obvious signs of intoxication or high suspicion of intoxication, they can be transported directly to the Sobering Center instead of to a hospital ED, right? And a Sobering Center has a couple advantages over hospital ED. One, it reduces hospital overcrowding, but two, there's an on-site case manager who works specifically with this population. And lastly, for my colleagues in EMS6, our high frequency EMS utilizer team, it actually provides a centralized location to find people, right? But so that is the Sobering Center as it was prior to COVID. Now, what happened? The managed alcohol program's inception was one of necessity. At the beginning of COVID in May 2020, there was an outbreak inside of the Sobering Center, right? And we had an exposure of about 17 individuals. So that necessitated an immediate closure of the Sobering Center and created an immediate need for a specialized isolation and quarantine site, an INQ site that could accommodate folks who both needed to be isolated from undergo COVID quarantine, but also still manage their alcohol use disorder. So what did we do? We partnered with our Department of Public Health colleagues, our EMS6 high frequency utilizer team, canvassed the city. They found, out of those 17 folks, they found 11 of those folks on the streets. And those folks agreed to come to an INQ site, which was a Project Roomkey hotel. And actually, I shouldn't say it was Project Roomkey, but it was a hotel the city had leased, and rapidly mobilized, very, very rapidly mobilized this site for these individuals. Now, what is managed alcohol? These folks live here at this hotel. There's laundry, there's food on site, there's 24-hour nursing, and the nursing staff here give the residents or the clients standard dose equivalents of alcohol at a metered dose based on clinical need. And what we have found is in our initial data from several months of this program is that the folks that are inhabiting the managed alcohol program were some of the highest utilizers of emergency departments in EMS prior to their entrance into the program. After their entrance to the program, when we look at their EMS and hospital utilization, we see drastic, and I'm using that, I'm overemphasizing that, reductions in their EMS utilization. I'm on average, I'm looking at my eyes are off to the side. If we are comparing 6 months of utilization prior to entrance to managed alcohol, and if we extrapolate to their 6 months of utilization after entrance into managed alcohol, we see a 94% reduction in EMS and ED utilization. So really, really incredible work by the folks here. Now, our involvement as community paramedics didn't end with finding these individuals and getting them to this site. We actually, for the first, up until recently, we embedded a community paramedic captain at this site to help staff there. And so we located the PUIs, persons under investigation in the community. We arranged for COVID testing, and then we actually embedded a community paramedic captain at the site itself. And now what did that do? They were able to triage those 911 activations when they did occur at the site and make sure they were appropriate and getting the correct medical response, assist with scene management during those times. They leveraged a lot of pre-existing relationships we had with clients as EMS providers. And as the program has progressed, our EMS 6 team has been a big component of sourcing new clients and new referrals, right? As we engage high utilizers in the community with severe alcohol use disorder, we are the ones who are feeding referrals and finding appropriate placements for the managed alcohol program. So that is all I can speak to the managed alcohol program off the top of my head. I probably could answer a couple of questions during the Q&A, but if I were to leave folks here with one thing, it's that it's been an incredible success in terms of utilization, and we've also seen a lot of specific cases of folks really stabilizing and re-entering the community and finding a level of stability they haven't found before in their lives. Thank you.
Thanks so much, Captain Mason, and really appreciate your summary of the street overdose response team as well. Really great programs that are happening, with interdisciplinary collaboration on both counts. So I think that's a really great segue. I'm sure the attendees, and we have more questions for the panel discussion time, so we'll have that in the discussion at the end. But a great segue to our next speaker. Welcome to Dr. Hillary Kunins from San Francisco Department of Public Health. By way of introduction, for those who have not yet met her, Dr. Kunins joined SFDPH in March of 2021 as the Director of Behavioral Health Services and Mental Health SF. And she came by way of New York City, where she had served as the Executive Deputy Commissioner of Mental Hygiene and the Assistant Commissioner for the Bureau of Alcohol and Drug Use at various times over the last decade at the New York City Department of Health and Mental Hygiene. And while there, she led the reimagining of New York City's public health approach to substance use, including overdose. And served as the Department of Health lead for Mayor de Blasio's $60 million Healing NYC initiative to address the overdose epidemic. Similar, in addition to her primary specialty, so Dr. Kunins is a general internist, but in addition to that primary specialty, she is an addiction medicine physician. And has dedicated her career to health equity for people with behavioral health concerns, including substance use and serious mental health issues. So thank you, Dr. Kunins. I know you're going to talk about the general approach that you're taking to reimagining mental health and substance use treatment and management and harm reduction in San Francisco. So we're excited to hear you speak today.
Thanks so much. And it was great to hear Mike Mason's presentation. So I hope to complement some of the things that he shared with the group and to contextualize, I think, the work, the really important work of EMS 6 and the SORT teams, as well as managed alcohol. These are extremely important interventions and also need the backbone and backdrop of the larger behavioral health systems of care. So I do have slides, and wondering if someone will share them or.
Sorry, yes, one moment. Did you send them to us?
Yes, just
Okay.
this morning.
Okay, one moment. So some technical issues, stand by. And what we'll do, Virginia. I don't see them.
I don't see it attached. Can you resend it to me again, and then I can.
It may have been too heavy, so not sure if you're able to share your screen.
Okay, let me give that a try. Sorry. And can folks see that?
Yes, we can.
Oh.
And if you go into into the slideshow, then
Yep.
you'll be able to.
Let's see if that works. Okay, fantastic.
We are seeing presenter notes. So if you go up to that display settings up there in the upper left and swap displays.
Yep.
Yep, that's it.
That's great. Thanks so much.
Oh, now it's cropped for me. Is anyone else seeing that cropped, or is that just me?
I see it cropped too.
Okay. Let's try it again.
There you go. I think you're in presenter view. So if you just can share slideshow. There you go. Perfect.
Great.
I'm
Thanks.
still seeing it cropped. I'm not seeing San Francisco on the left there.
On the left.
So let's do this. Go ahead and exit out of your slideshow.
Yep.
And when you go to share, can you do a new share and choose your second screen rather than your first screen on Zoom?
I'm sorry, say that again.
First question is, do you need your presenter notes?
No.
Okay, then just launch your slideshow again. And then instead of swap displays, we're gonna do duplicate. Thank you. There we go, perfect, thank you.
Okay. I got one screen sideways, the other one the right way. Okay, let's see if we can make this work. Thanks all for bearing with us. So as I mentioned, and as Dr. Mercer just introduced, I'm still relatively new to San Francisco Director of Behavioral Health Services and Mental Health SF, and so it's great to be here and continue to learn about the great services and important work happening here in San Francisco. I wanted to spend some time really, I think, contextualizing the work around behavioral health that Mike Mason just shared with you by focusing on new work happening in the context of something called Mental Health SF, as well as the overdose prevention landscape in San Francisco. I did want to spend a little bit of time on children and youth, as well as the work that we are undertaking to center and address racial inequities by examining our service delivery system and tracking and changing the way we both hold ourselves and our providers accountable for outcomes. So overall at the health department, our goals around behavioral health are to increase quality of life and reduce mortality among all people in San Francisco with serious mental illness or substance use issues. And a central vehicle, although not the only one, is to improve access to and quality of care for mental health and service and substance use treatment. One of our key, or some of our key priorities to achieve those goals is to reach and treat people experiencing homelessness. And I think, as you just heard, EMS-6 and pre-hospital care is really a vital part of that. Our priority, as you just heard, is to reduce overdose deaths. And in order to deliver really on these goals is the pressing need to strengthen the behavioral health services workforce. Our guiding priorities include racial equity, the need to fill gaps in levels of care, and the need to have sufficient proactive and low threshold services. This really represents a departure for the behavioral health sector in how services have historically been funded and conceived of. And so I know that these kinds of changes really are vital, but can be really challenging for our sector. I wanted to share with you also the landscape of the safety net of behavioral health. I think that many of us, and you all are familiar, probably most familiar with some of the more severe end, hospitalization, crisis programs in the dark blue and the lighter blue. These two levels of care ideally happen in a continuum that ranges in the most upstream fashion to early intervention programs and prevention programs, an array of street and community-based supports, some of which you interact with most likely. Probably less frequently, outpatient treatment and residential treatment are vital to the care continuum. And then finally, at the tip of the pyramid are locked facilities where we know there is a need, but we try to use in the most sparing way possible. I'll also call your attention to the right side of this slide, which is a list of residential care settings. Similar to, I think, what we're all reading about in the newspaper, both here in California, in the Bay Area, but also nationally, is that the profound shortage of housing and residential care settings really is not only obviously a personal challenge for all the people we're interacting with, but also is a health problem that when people are unhoused, their health outcomes, including their mortality, and you heard about that from Mike as well. And so we are working very closely both within DPH and across city agencies to expand access to permanent housing, transitional housing, as well as the kinds of residential care that is run out of DPH, cooperative housing for people with mental illness, residential step down, and I'll talk a little more about that later, as well as all the non-specialty kinds of affordable and other housing that's being expanded in San Francisco and beyond. So our safety net system, just to give you a sense of scale, served about 20,000 people in our what's called specialty care system, one of our mental health, substance use, either direct or contracted programs. We also provided prevention and early intervention services to more than 20,000 additional people These were delivered in a variety of ways and in a variety of settings, and you can see those below. These services don't account for the large number of behavioral health services happening outside of our DPH specialty care system, like in primary care, like in street medicine. And so this is really a significant portion, but not the whole spectrum of who Department of Public Health is touching. What really has influenced our work over the last 2 years, and I joined, as you heard from Dr. Mercer in March, is that in 2019, the San Francisco Board of Supervisors passed a piece of legislation called Mental Health SF. The goals of Mental Health SF are consonant with our goals in the Division of Behavioral Health Services, with a focus on people experiencing homelessness. That legislation named 4 different programmatic areas that we are working to build out. The Office of Coordinated Care, the Mental Health Services Center, new beds and facilities, and our Street Crisis Response Team in partnership with EMS-6. I want to just spend a little time on those elements because I think they're so vital to what is coming or has been started up since the legislation passed, and how much I'm optimistic about assisting the behavioral health work here at the health department to meet the key goals and priorities. So the office, so we know that behavioral health care, similar to other kinds of healthcare, is highly fragmented and is challenged by the fact that we've not been adequately resourced to attract people to care, retain them in care, and find or do follow-up when they fall out of care. So we are in the process of setting up what we are going to be calling an Office of Coordinated Care. This office will have different aspects to it, and you can see them on the slide in front of you. Some of these names are sort of wonky and under development, so we hope to have some catchier names by the time we launch in the next year. We will have a central coordinating team that really ensures care coordination for priority populations, including the ones that we have been speaking of, people who are experiencing homelessness, but also in transitional moments, leaving jail or hospital, returning home from these settings is really a time of both increased risk of overdose, but also increased risk of other kinds of behavioral health crises. We will have a team, the CCTM team, the Care Coordination Transition Management team, that will have field workers, case managers who provide short-term linkage and follow-up, similar to what you heard about from Mike, that there will be a follow-up team with SORT. These teams will have a similar role for people with behavioral health needs across the spectrum. We are building out and just recently launched actually a new telephone line with new systems to do better tracking and more technology to know about wait times, dropped calls, and so forth. In addition, we are expanding the hours of our Behavioral Health Access Center. We will develop capacity to do member services, that is Medi-Cal, but also people who are uninsured, to raise awareness and pull people into care. They will also have some basic Medicaid functions, Medi-Cal functions like eligibility for services, as well as transportation services. So we are really trying to build out an office for whom coordinated care is their primary overarching responsibility and role. As part of MHSF and also the important shared work with EMS-6 is our Street Crisis Response Team. This was the first program under MHSF to launch almost a year ago. These teams are multidisciplinary. In addition to the EMS worker, consists of a behavioral health clinician and a person with lived experience or peer worker. We are now operating 24/7 each. The opportunity is to reduce unnecessary use of law enforcement, unnecessary use of emergency department services, and with a handoff to our nascent care coordination team, the opportunity to have community follow-up to connect to care. A next element of MHSF is our residential care and treatment, or fondly, our new beds and facility group. We know that there is really a gap in access to residential care and treatment across that pyramid of spectrum that I showed you earlier. And so we are working to implement a range of residential care settings that were first identified in a bed reform analysis completed under Dr. Anton Negussi-Bland, who some of you may know. We have developed, and you can see this example in front of you from mid-October, our bed dashboard, and this is also available publicly and on our website. I just want to highlight a few of the programs that have opened under MHSF, some of which you may well be familiar with. I'll call your attention first to the second one here, which Mike was just speaking about, the managed alcohol program, and that is open with approximately 10 beds. We are aiming to expand those further to 20 beds. I'll also call your attention to the first item on that list, Hummingbird Valencia. This is based on a successful model at Potrero, Hummingbird Potrero, and this is really a psychiatric respite center. It is intended to be a low threshold drop-off space with both day and overnight capacity. It is a welcoming space for people to get both physical health needs met, like food, shelter, hygiene, as well as connections to ongoing care. It is intended as a drop-off space for services that we are starting up, as you just heard about, like SORT potentially, like SCIRT, Street Crisis Response Teams, and others as welcoming spaces. At the other more severe end of the spectrum, we are also opening longer-term, both locked and voluntary spaces. We've opened 12-month rehabilitative board and care sites. These are long-term care settings for people who need help with their daily living, as well as connections to rehabilitative care. And finally, we are also have opened more mental health rehabilitation beds. These also are known locally as locked subacute treatment, or LSAT beds. We have 20 beds now available accepting placement. So I think the thing I'll stress is that in filling out our care continuum, we need a number of different levels of care and intensity of care in the residential or overnight domain. I want to also just mention one more, which is on the right side of your screen, sort of midway down, which is residential step down. This is a level of care for folks coming out of residential substance use disorder treatment. Specifically, this is longer term, up to 24 months, acknowledging the importance of having stable living space as people are exiting treatment, and support for accessing longer term housing. This will also help free up the residential substance use treatment beds and unlock availability of some of those. So switching gears, so those were some key examples from MHSF, some Street Crisis Response Team, residential care and treatment, and our Office of Coordinated Care, which includes our Mental Health Service Center. I want to just also mention how important behavioral health care is for children, youth, and families. And this is really a good chunk of what we also do. We conduct prevention and early intervention. We seek to invest in whole family care to prevent and address needs in early life, and ideally to prevent some of the later life crises that we are all seeing on the streets. This includes both specialized and integrated programming with our partners across the city. You can see them on your slide. And we really aim to provide and offer services that are developmentally appropriate across the age spectrum, including younger, early childhood, as well as middle and late childhood and adolescence. We know that the impact of COVID on children and youth has been great. I think many of us may be seeing this in both our personal and professional lives. And we are hearing about increases in acuity, including use of crisis, emergency, and inpatient services. We know also in San Francisco, in the Bay Area, and also in California, there's really a profound shortage of inpatient services for children and youth. And we are working both with our state partners as well as our advocacy organizations to find ways to increase access to those vital services. I also want to mention, in the context of crisis and sort of the analogous behavioral health pre-hospital care, is one thing that we were able to expand during COVID is our mobile crisis team for kids. We respond to youth with serious behavioral health concerns, including suicidal or homicidal ideation, self-injury, other destructive behavior, sorry. We are working with all schools now. We are working with all kids and families who are accessing services through behavioral health at DPH. And we are aiming to provide crisis response within 1 hour. And that is really an expanded capacity beyond what we had previously had. I know this may still sound slow to folks working in EMS settings, but on the behavioral health landscape where our mobile teams have been really sparsely funded, this really represents a great improvement. And we are very happy about that and hope to do even better. As I mentioned, we are seeking opportunities to reduce inequities in racial outcomes in a number of different ways. And I just want to highlight one particular intervention initiative that will be starting up this year, and that is culturally congruent services in our outpatient behavioral health programs. We will be launching this service for Black African American residents in San Francisco, using a number of techniques and scientifically evidence-based strategies, including hiring clinicians who identify as Black African American. We know that outcomes can be improved when there are racially concordant clinicians and clients. We are also looking to implement African-centered storytelling and expressive arts practices, which have been found in other trials to benefit clients and improve outcomes as well as retention and care. And we are looking to partner with community groups holding trauma-informed community healing circles, along with our partners from faith-based organizations and community settings. So more to come if you invite me back on all that. So finally, I just want to end with a few minutes speaking to you about overdose specifically. I want to mention, so as you just heard from Mike, and as you know from reading the large amount of media, San Francisco is experiencing an overdose epidemic that is disproportionately affecting Black African Americans here in San Francisco. We know that overdose deaths are preventable, and we know we need to be doing more, and that saving lives, we're fortunate here in San Francisco, can build on our backbone of services, as well as our equity-driven and stigma-busting and proactive approaches. So I just want to share some additional context to that that Mike presented. I'm going to skip the data slides because I saw that that you know already about the rapid rise in overdose deaths in San Francisco, and particularly being driven by fentanyl. let me spend just a moment on this slide, and what I just want to point out here, which I think illustrates it so well, is the large contribution of fentanyl to the opioid-related deaths in San Francisco. That's the gray, increasing in 2019, and then further increasing in 2020. Similarly, I also want to call your attention to the disproportionate rate of opioid-involved overdose deaths among Black African American in San Francisco that has been increasing out of proportion to that of other San Franciscans. And you can see that by the blue bar in the rightmost cluster of bars from 2019. I think Mike already mentioned that we have disproportionate number of overdoses among people experiencing homelessness, most recently about 1/3 of those deaths. And the last factoid, just to reinforce, is the extent to which overdose what is driving overdose deaths among people experiencing homelessness is overdose. The vast majority of deaths among people experiencing homelessness are due to overdose. So the San Francisco context is that we have a lot of services, really remarkable existing services that help reduce risk of overdose. And for many years, until this recent entry of fentanyl, San Francisco was really held up and held out as a sort of example of what goes well, what can go well. And part of what attracted me to come work in San Francisco was this array of services: available substance use treatment, despite some challenges in access, a remarkable behavioral health pharmacy run by the Department of Health, street medicine services for people experiencing homelessness. Syringe access programs have been long-standing and offer an array of services. And this city, including, as you mentioned by Project Friend, early adopter of community naloxone distribution. But we need to do more, and we are looking for ways to do more in addition to what I have put out here. What I'm sharing with you is really a framework for how we are thinking about what additional work we can do to reduce overdose deaths. We need to do more overdose education and distribution of harm reduction supplies by expanding naloxone to get into even more social networks, expanding fentanyl test strips, which you've just heard about, as well as other consumption supplies. We want to aggressively continue to remove access to barriers to high impact treatment. And by high impact treatment, we know that treatment that includes the use of a medication, specifically buprenorphine or methadone, shows the best outcomes in multiple scientific studies. And we are looking for ways to expand low threshold buprenorphine. As you heard from Mike, one example is having EMS 6 workers be able to start buprenorphine in the field and then link rapidly to ongoing care. We also have done a number of other innovations like buprenorphine telemedicine, which has been permitted by changes in federal and state regulation. We are expanding connections to care. That is, when someone presents for care, looking for opportunities to fund navigation systems, both through MHSF, but also special programs like 2 at UCSF, the General, Houdini Link, and the Bridge. Let me also mention another effective strategy, which is contingency management. This is essentially providing rapid, timely awards to people for desired health outcomes, whether it's keeping a medical appointment, showing up for a counseling visit, providing a urine toxicology that does not contain substances. This approach has been found effective, particularly in trials around using stimulants, but also getting folks to be retained in care for opioid and alcohol use disorders. And we are looking for ways to implement contingency management widely. We will also be funding 24/7 access to methadone treatment and expanding our pharmacy hours. We already taught, and I think, Mike, you made an incredible case for a strategic and focused response on people experiencing non-fatal overdose. And the SORT program, which you heard about, is really a huge, important piece of this overall framework and puzzle. I want to just mention on the right an approach to really address stigma, increase social support, and improve and reduce racial inequity. So upstream, in addition to these very high impact services. This is where both our low threshold supportive programs like SOMA RISE, which is going to be our methamphetamine and opioid sobering center to be opening in the winter. I mentioned Hummingbird Valencia. I would count another approach, safer consumption spaces in this landscape, creating social support and opportunities for folks who are at risk to connect to services and help they want. Finally, we need to approach this engaging all the folks around the city through community education and organizing to find out what other needs are in Black African American communities, in other communities and places where we need to do better and reach more people. I'm going to skip this. And just kind of mention finally to end, in addition to all these interventions, and this is really a message for clinicians generally about what we think and are 4 key strategies to reduce risk of overdose. If you are a clinician or working in any kind of clinical setting, and I didn't really talk about judicious opioid analgesic prescribing, both in post-operative and emergency care settings. As the opioid and fentanyl epidemic have taken off, some focus has shifted away from opioid pain relievers, but they are nonetheless part of this picture. We've talked a lot about ways to increase access to buprenorphine treatment in primary and specialty care settings, and I'll just add now pre-hospital settings. We need to establish routine naloxone prescribing and access for all people who are likely to either experience or witness an overdose. And we need to establish standardized responses to non-fatal overdose. And I think we're very much doing that here with the SORT program and looking forward to reaching out more into other emergency settings as well. So, and finally, I'll leave you here. This is our pretty new website. We are really aiming to make our services more understandable and accessible and help San Franciscans know where to get help. You can see the links in front of you, and we can send out these slides, as well as a screenshot of our just launched front page to how to get help. And thanks so much. I'll end there.
Thank you so much, Dr. Kunins. So if people do have questions, can put them in the Q&A, and we'll be sure to send them to for the panel as well. There was a question, and unfortunately, Dr. Glenn had to drop off, but I think we'll have if she's able to join us back at the panel time, have a interesting discussion comparing programs from Arizona and the SORT program in San Francisco for both you and Captain Mason around the opt-in versus opt-out kind of format there. All right, so without further ado, I will introduce Dr. Kathy Lesaint, who will be presenting on Project Friend overview to date, what progress has been made, and kind of future directions and support for Project Friend related partnerships and programs through San Francisco General Emergency Department. So Dr. Lesaint is an emergency physician and toxicologist at San Francisco General, and the program director for Project Friend, and now for a new future state for Project Friend called Project Friend Connect, which hopes to further facilitate warm handoffs into the mental health and substance use treatment programs within San Francisco. So thanks, Dr. Lesaint.
Thanks so much. I'm going to share my slides here and then start my slideshow. Oh, okay. As Mary said, my name is Kathy Lesaint. I am the, I would say, co-project director for Project Friend, along with Dr. Mercer there. And in the next half an hour, I just want to talk about the overview of Project Friend, what our initial goals were, what kind of impact we've made thus far in the last few years, and then future directions for our team. My disclosures are that I do receive salary support via grant funding for various projects related to the treatment of patients with substance use disorder. My salary support comes from SAMHSA, the Public Health Institute, and California Department of Healthcare Services, but again, all related to treatment of patients with substance use disorder. Project Friend, in the early stages, received funding in September 2008 from the Substance Abuse and Mental Health Services Administration. It received funding as a 4-year project to increase naloxone distribution in the city of San Francisco. For the first year of the project, we focused on logistical planning, and we developed a few teams. We developed a core team, a consultant team, an advisory team, and a team of project champions to help us come up with a very, very clear plan as to how to move forward. So it did take a year for this logistical planning phase. I would not be here without the help of the following people. So the next couple of slides are just going to be everyone who's been involved in this project thus far. We have the core team. I've already explained myself. We have Dr. Mary Mercer, who has already, who you've seen during these last couple of hours. I would not be here without her help in writing the grant. And she wears lots of hats. For this particular program, she wears the hat of emergency medicine physician with and base hospital EMS physician as well. We have the lead evaluator for this program, Dr. Juan Carlos Montoy. He brings to us a wealth of knowledge regarding behavioral economics and research. We have Dr. Eric Silverman, who is also an emergency medicine physician, also wears a couple of EMS hats as well, who is also the medical director of King American Ambulance Company, and brings to us his knowledge of creating curriculum, and he is the lead educator for this project. And then we have Virginia Chan, who is also on this call, and she is a clinical research coordinator for the Department of Emergency Medicine at UCSF and our project coordinator. We have a number of advisors and consultants for this project. We have Dr. John Brown, who brings expertise in the EMS setting, Dr. Philip Coffin, who brings us expertise from the Department of Public Health and research related to patients related with substance use disorder, and Dr. Maria Raven, who is the medical director of the emergency department at UCSF, and who brings to us who brings to us knowledge of evaluating large programs. This is an advisory committee. In the beginning of this program, we thought that it was very important to bring together stakeholders from all around the city with knowledge in harm reduction, with knowledge in pharmacy, with knowledge in the EMS system, with knowledge in emergency medicine care. And I won't go over everyone here, but this is a team that we met with quite frequently to develop curriculum and develop, again, just planning this entire project from the start. And this was the three that are here are Project Friend champions. And so in the beginning of this project, we said, hey, we were just wondering if there are any people on the ground who feel like they want to be involved in the planning process for creation of an naloxone distribution program. And we got hands up from Emily, Raymond, Ryan, and Sam oh, Sam, I know you're on this call and I always butcher your name. And they have been very, very helpful with just providing feedback to us from folks who are actually on the ground and who are actually seeing patients. So in year one, what did we do? What was the logistical planning phase? How did we get this off the ground to develop a naloxone distribution program? So some of the highlights of this first year included working with the state and local EMS agencies and the California Department of Healthcare Services regarding legal requirements for the EMS policy and protocol wording. And so there was a lot of back and forth talk, and approvals needed to be met to change. We conducted focus groups of EMS providers, and we reviewed and then reviewed some more drafts of this pilot program for Leave Behind Naloxone. What do you think will work? What do you think won't work? We received approval for the local optional scope of practice expansion to include naloxone distribution by paramedics. And again, this has not happened before. Typically, our on the ground providers are not distributing medications or administering them, but not distributing them. So this was definitely very new. The core team, along with the advisors and the advisory committee, drafted a curriculum. How do we tell our providers about this program? What are we asking them to do? And then with our lead evaluator and our evaluator advisor, we developed an evaluation plan. What can we study out of this? What kind of data could we gather that we could share with other folks trying to do the same thing? So one of the things that we did as a team was we wanted to see, how do EMS providers feel about naloxone distribution programs? Is this something that should be happening? Is this something that shouldn't be happening? And so we went to the 3 ambulance companies in San Francisco Fire, King American, and American Medical Response. And we conducted a voluntary survey of folks to see how they felt about us making a program like this. We received 150 survey respondents over a 2-month period. 77% identified as male. The median age for this group was 33 years, and the median years as an EMS provider was 7 years. And so how did people feel about this? And we asked, did you think that a naloxone distribution program by EMS is effective in reducing overdose deaths? 8% thought that the program would be very effective in reducing deaths. 43% thought that it'd be somewhat effective. 2% thought that it would not be effective at all. Another question we asked is, should EMS providers, should they be the one to train others to administer naloxone? Clearly, they know how to administer naloxone. Should they be training lay people in the field? 67% said, yes, that is something that we should be doing as healthcare providers. 7% said no, and 26% said neither no nor yes. They felt indifferent about it. And we asked, what concerns do you have about starting an EMS-based naloxone distribution program? And 20% said, they felt uncomfortable with it because naloxone distribution programs, giving people naloxone can increase rates of precipitate withdrawal in the pre-hospital setting, and that's not fun for anybody. Assault, meaning if a person is reversed, then they can get very agitated and they can maybe be combative. Maybe naloxone distribution, just having a lot of naloxone can actually enable substance use, or having too much naloxone can increase inappropriate administration, maybe giving it to someone who you really shouldn't be giving it to. And so at the get-go, these are some of the, we just wanted to get a baseline as how did people feel about this program coming to be. I would say I think just based on these numbers, people felt pretty positive. Sorry, everyone. Just going to. All right. We're doing double duty here. Okay. So that's how people felt before we did it. Okay, so what did we do? So first, we applied for naloxone to have, for a Project Friend team to have. And so we tapped into free naloxone from the Naloxone Distribution Project in California. So around the same time, the state of California received funding for naloxone. The state of California received funding to distribute naloxone to programs that needed it. And so we applied and we received in the first year 1,200 naloxone kits that we could give to the 3 EMS companies for distribution. We implemented a few in-person training sessions. We said, hey, we're going to be here at, say, one of our training sessions was at AMR. We said, hey, we're going to be here. If you're around and you're available, we'd love to give you an in-person talk about why we're doing this program and what kind of data we're going to collect. For the rest of the folks who could not make it, we created a video tutorial. And this is just the screenshot, but it's a video tutorial about Project Friend, about why we were doing what we were doing, about who to give naloxone to, and if you did give naloxone, what we'd like you to do subsequent to that. And so this was widely distributed across all EMS, the 3 EMS companies, and for all the hundreds of folks on the ground to watch. So what we asked folks to do was, in the case that they were going to distribute a kit of naloxone, that they would register this kit. And what that meant was we pasted a QR code on every naloxone kit box. And we asked EMS providers before they give out the kit to use their cell phone to open up the survey attached to that QR code, which would let us know who they were giving the kit to, where they were giving the kit, and in what situation they were giving the kit for. So here are a few results from the first year of this program. In person, we trained 224 people. 29 EMS providers attended one of the in-person training sessions, and then 195 EMS providers we caught just before or after shift. So one of our team members went to either SF Fire, AMR, or King American and did some teaching at the station for folks who were coming off or coming on their shift. And as I mentioned, 1,200 naloxone kits were distributed to the 3 SF EMS provider companies. Of the 1,200 kits that were distributed across the 3 SF EMS companies, 19% were registered over the first 12 months. Now, this is not a big number. But this was enough for us to collect initial data on the type of patients who were getting these kits. I do want to say that we stressed that, hey, if you're super duper busy and for some reason you just couldn't register the kit, that's okay. Our goal really was low barrier distribution, meaning let's just get the kits out there, because our overall goal is to increase naloxone use for patients who needed it and to reduce overdose deaths. It wasn't, hey, like you have to register each kit. And so I think the kits got out there, not a lot of them were registered. We tried to increase some of the outreach to increase registration. I can talk about that in a little bit. But this is what we had for the first year. So An average of 19 kits were registered per month. The highest number of registered kits, and this makes sense, was recorded during the first month. There was no correlation or rise in the number of kits with our outreach, unfortunately. So what kind of patients receive these kits from our EMS providers? Well, 146 of the 232 registered kits were given out when EMS responded to an opioid overdose event. The other kits were maybe someone came with chest pain and someone called 911 with chest pain, and then EMS providers noticed, oh, you have a lot of opioids in your home, is this something that you would find beneficial? And so that's like an example of another case in which naloxone would be distributed. Again, not surprising is that a majority of the kits were distributed in the downtown and civic center neighborhood of San Francisco. A majority of the kits went to patients themselves, while some went to bystanders, some went to the patient's friend or family member. A majority of them identified as male. A majority of them were white race. And the median age for those who received the kits was 37.5-year-old. Here's some up-to-date data. So the data I presented in the last few slides was from the first year of the program. This is data up until now, from 2019 to just about a month ago. And so we have the number of, in the gray bars is the number of kits supplied to the organization, AKA the number of kits that have been given out. And the orange bar is the number of kits actually registered by each organization and some of the data that we've been collecting. One of the things I haven't mentioned is that we provided monetary incentives for EMS providers who registered the kits. And so every month we took all the registrations and we did a lottery, and we gave $100 to an EMS provider who registered a kit every month from the start of the program. And so every month someone got $100. We also incentivized EMS providers if they got on scene and saw that someone had been reversed with Project Friend naloxone. If that was registered using the QR code, the EMS provider would automatically receive $10. And so you can see in this bar graph here how much was given to a member of each of the three EMS companies, with, let's see, King American receiving, King American EMS providers receiving a lot of the monthly lottery for $100, and then SF Fire reporting a lot of the overdose reversal treated with Project Friend naloxone. During the project period, we also focused on outreach and creation of advertisements. We've been generating a newsletter that has been widely distributed for about twice a year. And this is a screenshot from the newsletter that was distributed in November 2020. And just we put on there reminders to EMS folks, and we also try to include an article that was relevant to the treatment of patients with substance use disorder. For example, one of the articles that we solicited to be written was from a member of the Drug Overdose and Prevention Education Program. And so we had this wonderful person write us an article about harm reduction and best harm reduction practices that can be utilized by EMS providers in the field. And so we try to make it very relevant to our pre-hospital providers in that way. We piloted signs to be posted on every ambulance rig in this city. We laminated these small signs and we gave them to the operation managers at each of the 3 companies. And here we had hoped to remind folks to give out the naloxone when appropriate. We also wanted to remind folks to register the kits. And so this is something that we posted throughout the EMS system as well. We also did some outreach and advertisement by publishing in the EMS and emergency medicine literature. We wrote, the core team wrote up our data from the first year implementation. We also wrote up our data from the survey study and had abstracts accepted to the National Society of Academic Emergency Medicine conferences in 2019 and 2020. The paper regarding the EMS for medicine services providers' attitudes was published just in, says January 2022 here, but it was published this month. And then our paper regarding the implementation of this project is currently under review. So what are our future directions for Project Friend? What are we doing now that the project is underway? We are continuing developing outreach protocols and trying to still collect data on patients who are receiving naloxone, but what else do we have under our sleeve? Well, what we wanted to do was partner with the Department of Public Health, ambulatory care sector to really increase naloxone distribution, or excuse me, increase naloxone use even further in the city. And so we supplied these 3 organizations with naloxone kits from Project Friend, and just for staff to use. And so we reached out to ambulatory care partners and we said, hey, would anybody want naloxone kits to have? And you could be like a lay first responder. And so these 3 organizations, they said, yep, give us some. We're happy to register the kits if we were to ever use them in the field. And so that's currently going on right now. And then most recently, we received additional funding from SAMHSA for a 5-year project, which we've entitled Project Friend Connect. And this answers the question, hey, for everyone who's given naloxone, that's maybe one intervention that we did for Project Friend. What else can you offer these patients other than naloxone? How can you help treat them? And so we developed a protocol in which we would enroll patients into a 6-month program, providing them with contingency management, AKA monetary incentives, provide them with motivational interviewing via a patient navigator, so that they would have follow-up in-person and phone visits over the course of 6 months to hopefully get them started on medications for opioid use disorder and looking for outcomes and reduction of other effects of substance use. And so again, this was recently funded, and what we're trying to do is really, you all heard about the SORT program just a little bit ago, and about just other wonderful programs in the city. And so our current task is how to align Project Friend Connect with other similar programs in the city. This is a flow diagram created by our lead evaluator, Dr. Montori, and this is, again, this is something that we're still hashing out. This is not set in stone. This is something that we initially envisioned, but again, it's still up for a lot of discussion and alignment with other projects that are going on. But our intervention includes enrolling patients who are adults with overdose in the field and connecting them with a patient navigator to get them started on medications for opioid use disorder. Perhaps we will focus on housed individuals, as SORT has been focusing on unhoused individuals. But again, this is up for still up for discussion, how we can best conduct this project. Wonderfully, we've been able to partner with the Substance Use Disorder Clinic at San Francisco General Hospital. We, as a part of Project Friend Connect, our hope is to connect the patient to another program which exists, which is a California Bridge program, Bridge Clinic. And this is a clinic at the General that's specifically focused on treating patients with substance use disorder. And so in addition to having the patient navigator in the field, really connecting them to this wonderful clinic that exists in the city. This might be my last slide. And so I just want to conclude there saying that, we've done a tremendous amount of work since the receipt of funding in 2018. The program started in 2019. We've been able to thus far collect a lot of data, and we have some exciting future directions to go.
Thanks, Dr. Lesaint. So we have, that was a nice summary, and I think just one of the notes that I had from kind of looking at that retrospective of kind of the work to date and starting up the program, just you can tell both from Captain Mason and Dr. Kunins' presentations as well, when shared alongside yours, is I remember in the early days of the 2018 development and starting the protocol, notably the naloxone distribution protocol for EMS that started by Project Friend was the first in the state of California, and really helped lead to a lot of other programs cropping up across other EMS systems. And we, having worked with Dr. Hearn, who we had present here last year on the fabulous program in Contra Costa that kind of leapt ahead to buprenorphine and MAT treatment referrals from the pre-hospital setting, and just seeing the collaborations with the EMS6 program and Department of Health that, with their deep expertise in the managed patient population, high utilizer population, and of multiple systems and the mental health systems and public health perspective, really seeing the SORT program skyrocket kind of that vision forward has been very gratifying. So finding those connections forward for how our usual 911 providers who are not necessarily community paramedicine or substance use treatment trained can also, play a role in the continuum of care and the in that cycle. And how also we can engage with other EDs. So you mentioned the Bridge program for California Bridge. So how can the same kind of warm handoff that may be happening into the Project Friend program or at the EDs into the SORT team, how we can make sure that that's happening from other folks that are being encountered with substance use disorder from other EDs. So really great. So why don't we move over to our panel discussion? There may be some additional questions. We had one question pop up in response to Dr. Glenn's program in Arizona around naloxone distribution and then referral to medically assisted therapy there. In terms of their substance use navigator referrals from the EMS system, they elected to have an opt-out program for the referral and follow-up. And notably, I know that when we've spoken with the SORT team and Dr. Kunins from both your experience here in San Francisco and then your experience in New York, I think prior programs that you have been involved in have elected for a opt-in program that someone has to consent actively to be followed up from for referral or follow-up with the substance use navigator. Would love to hear kind of the approach from the SORT team and your perspectives, Captain Mason, Dr. Kunins, around the issue around opt-in versus opt-out into navigation.
I'm hoping Dr. Kunins will speak first.
Thanks. Okay. So let me just, and I'll speak more from my work, frankly, in New York City, where we implemented a non-fatal overdose intervention program that involved peer workers being deployed to emergency departments 24/7. So we did not do this through EMTs or EMS workers. We made a couple of decisions. It was a complex set of decisions in consultation with our legal advisors and some principals. We made the decision that there would be consent. It was verbal consent. It was not a written consent procedure. We did this for several reasons to meet, because we were in hospitals that we did not run. We were outside the care system, and that was what the particular care setting recommended to us and felt comfortable with. And we also made this decision because there is so much, historically been so much punitive care of people using drugs who perhaps have been criminalized because of their substance use, despite having the medical illness, or because there have been sharing of names. Sort of on the law enforcement side, we really wanted, as public health, to kind of make, I guess, a sharp distinction between our approach, which would be completely voluntary and require patient consent, albeit verbal. I do think there are some missed opportunities, though, and I do think that in San Francisco, the landscape and the close partnership between, for example, EMS 6 and street medicine really and the fact that DPH runs the healthcare safety net system, or a good chunk of it, presents some different potential opportunities and maybe a different calculation. So how'd that go, Captain Mason?
I wanted to speak first so I could learn something. I have a much more narrow answer. Something that's been interesting that we've encountered is some folks have actually questioned, is it even okay to engage people in this context? In the context of 911 call, is it okay to start offering these services? And my answer is definitely. And in some of those consent issues that I think research consent issues and things like that and follow-up consent are very different when 911 has been activated and you are already in an ambulance or you're already in the scene of an emergency. So there's some context to that. And then for our specific program, our encounters end with kind of 3 or 4 ways, and one of which is it okay if someone from our follow-up team contacts you? And often it's verbal consent, and often that's as simple as, hey, you overdosed, you went to the ED, I took you from the ED to a shelter. Is it okay if a nurse practitioner comes by tomorrow and checks on you? And that's the extent that we verify people are open to that, but we keep it I think we keep it informal. But Dr. Kunins hit the nail on the head where people are, people are client, we use the word clients, but clients are concerned, well, is, who is going to check on me, or is my name going in a database? And so having that relationship with folks really helps to say, hey, it's someone from Tom Waddell Urgent Care, these folks, street medicine, they're the best. They really care about you, and they just want to check up on you and make sure you have all your medications and that your induction went okay and done. And so that's the extent of our verbal consent.
Thanks so much for sharing those perspectives. So would also just love to hear from your teams kind of what the feedback has been, or how you're incorporating feedback from patients who are going through the system or have been engaged in the system. I really appreciate you sharing kind of the overview of who is accessing resources, and kind of what methods are you examining to incorporate kind of patient informed changes to the program.
That was to me.
Yeah, I think to both you and Dr. Kunins, and then I think also I think that's an area that we're looking at on our end, and certainly have more time in the ED, but also trying to support that engagement.
I'll point to one specific program, and I know Dr. Kunins has a much wider vantage point than I do. The response teams, these are the vehicles that respond in real time with a community paramedic. We've been in operation for 3 months. In the next several months, we will start staffing them with peer support specialists. So I would say that we're incorporating that feedback actually with our staff to some extent. And these peer support specialists lived experience of substance use disorder or homelessness themselves. And often we employ this category of personnel on our street crisis response teams. Quite often, this is the person who leads the engagement, right? We have a mental health practitioner, we have a community paramedic, and it's the peer support specialist that is actually best at engaging folks and bringing that perspective. So that's one way we've incorporated that in our staffing model. As to, I think it's a fantastic question, how do we incorporate client feedback or patient feedback into our processes? I hope to have a better answer for you in about a year once we're fully iterated up.
Great, thanks so much. So Dr. Kunins, we really appreciated your overview of kind of mental health changes and the future state. And what are you, now that you've been here for not quite a year, but almost approaching, I guess, half a year, what are you, what support are you looking for, from the health systems, from EMS providers? Like, what message, kind of single set message, would you want to get out to EMS providers? Beyond the community paramedicine teams?
That's a great question. I think, let me just say, I think probably like the majority of the EMS providers come from training and intent, wanting to take care of physical health conditions, heart attacks, strokes, maybe me, not so much trauma because I'm an internist. But I think that when faced, and this is my own career trajectory, faced with the reality of caring for people, the learning is that so often it is, the particular issue is mixed up with people's behavioral health concerns, whether it's substance use or mental illness. And sometimes what is the most difficult part of caring for someone are those behavioral health challenges. And so I think the message is for all of you feeling challenged and challenged, and obviously you're in this session, so you have an interest in this, is that we are really trying to build out supports and structures at the city level to support all of you and all of us who are doing this really hard work of caring for people's both physical and behavioral health needs, which are often come all together in one person. So the message is, I think I empathize that it is a great challenge clinically, and we need to create systems that help help you with skills and also importantly access to additional services so that people feel, and I hope you do, optimistic that there are effective strategies, that people do recover. I think from my many years of being an addiction medicine physician, I had the advantage of the long-term relationships with patients and clients who are often invisible in the pre-hospital setting and invisible in emergency department settings, but it is in the context of a longitudinal primary care relationship or addiction medicine relationship where I saw lots and lots of people do extremely well. And so I feel optimistic, and I hope to bring you all to this space of optimism despite the very real challenges, but it is an enormous opportunity right now in San Francisco with lots of new resources and political will and interest to help all of us do better and do right by people. That wasn't one word.
No, but I think that's great, and it's also you know, what we're hoping to support, and I think it's when we think about EMS, you know, as a specialty, community paramedicine, community paramedics get that longitudinal perspective with their patients, with the clients, and I you know, I can't speak for you, Captain Mason, but I think that when starting Project Friend, specifically because EMS6 was focusing on some other priorities, it was started with the rest of the 911 system, but it was trying to provide that window of optimism too. And I think the more that we can share both the storytelling and, you know, those success stories, and I love that the SORT program and the collaboration there really provides that window into that optimistic future state for those of us either in EDs or out in ambulances, you know, to help patients, you know, engage in lots of different ways. So thank you for that perspective. All right, seeing no other questions here from the group, are there any other questions from the panelists to each other? I'll also just on that kind of optimism note and that perspective from Dr. Murphy's presentation around their findings for the treatment of alcohol use disorder and the high impact that case management had, particularly in those who experience housing instability. I think it also just speaks to our larger commitment, you know, as EMS and emergency medicine clinicians to be involved like in that larger social advocacy for factors that are outside of that have been historically outside of our healthcare realm, but are really important factors, you know, for our patients in this journey. Sorry, and Dr. Kunins, were you going to say something else?
You know, I was just going to ask Captain Mason and perhaps others on the call, really, my sense is that this very, very active role in San Francisco of community paramedicine in behavioral health and now very specifically overdose, and without knowing the landscape, I'm just curious to know to what extent is this happening in other parts of the country, state and country, and to what extent does this kind of represent some future of pre-hospital care?
Yeah, especially the other Project Friend principals here. You guys might have a additional perspective on this. My response would be through California Bridge and through working with medical directors from other counties. I think in terms of, if we're going to just talk about overdose response, I think we are a leader here from an EMS perspective. We're certainly not the first. So there's some other counties that we've learned a lot from and learned from their programming, specifically Contra Costa with their buprenorphine program. Their application to the state, I won't deny, was a big, was a big impetus to us, and they've been a big help to us, and we're actually pursuing some research with them as well. So I'd say my understanding from what I've learned is that we're a leader, but we're on the forefront. I don't know if that's the answer I'm looking for, if you're just looking for just overdose related perspective.
Yeah, I mean, I think that's right. I think San Francisco and California in particular. So this, you mentioned in your brief talk on alcohol use disorder, Captain Mason, the Sobering Center, I think it was created almost 20 years ago or over a decade ago, as an alternative destination, and achieved local optional scope. In California, EMS is pretty heavily regulated, and there are interactions, between different factions in healthcare. I think there are other states in the country that have taken much more expansive and permissive approaches to mobile integrated health, and therefore can capitalize on our wonderful skill set, within EMS. In California, we have to, and as emergency physicians, as addiction specialists, have to make sure to advocate for that really interdisciplinary approach that community paramedicine offers, in collaboration with public health and addiction medicine, to really address these problems that they go beyond one specialty or one form of medical care, and they really do require multidisciplinary perspectives. So I'll just say, I think the alternative destinations challenge has been a challenge in California, and I think community paramedicine and mobile integrated healthcare has been stymied because of our state kind of regulations and political factions more than it probably should be. But I think the more that we have programs such as SOAR and Contra Costa, the more that we are building, bridges across specialties for these interdisciplinary programs, and we have a chance to kind of also reform some of the regulations that are affecting kind of delivery of services to our patients, where they need it and when they need it. I'll get off my political soapbox though. All right, well, thank you. We have 1 minute remaining, so I'll give everyone a minute back of their time. Appreciate you making time for today's discussion and sharing all of the great developments across the city, and we're happy to be contributing to the future state as it unfolds. Thank you, everyone.
Thanks so much.